be the next speaker, and then we'll take the question.
Okay.
And then we can have a panel in the end if there is time. All three of us, if anybody wants to ask anything.
Fine.
Sir, I will start, and I will give the session to Birmani sir, and then Birmani sir will handle the.
Umangji, we can start the meeting now.
Okay. So, sir, good evening to all. Once again, sir, best regard from Ipca Dynova division. Myself is Umang Sekhar, and sir, I welcome you all to this panel. We are so lucky that we have such eminent panel. The doctors who is available here, they don't need any introduction from me, but I have got the opportunity to introduce. So I welcome Birmani sir. He is our chairperson from Jamshedpur. Apart from this, sir, we are having Dr. A.K. Das, Anil Kumar Das, who will speak about role of hydroxychloroquine in type 2 diabetes from Muzaffarpur. And the third one is there with Dr. Ajay Chhabra is there, who will elaborate about the vildagliptin in type 2 diabetes. So with this, I am handing over the session to Birmani sir. Welcome you, sir, Birmani sir. And please take the position. Thank you. Thank you very much.
Okay, thank you.
So handing the session to Birmani.
Pardon? Oh, am I audible?
Sir, sir, you please start. Yes, sir.
Yes, sir. Yes, sir.
I think good evening, everybody. We have got two excellent, handsome young speakers today, and two variety of topics. So we'll have first Dr. Amit Das from Muzaffarpur, or is it Muzaffarnagar? Muzaffarpur. Okay, Muzaffarpur. He's a very dynamic person, and I know him personally, a very handsome and dynamic man. And he's interested, excellent orator, as well as an academician. So he'll be talking on the role of HCQS in type 2 diabetes. We have been using this drug for connective tissue diseases and rheumatoid arthritis for more than, I think, 25, 30 years now. And recently it was approved for the treatment of diabetes as an add-on drug. Of course, this drug has also undergone a huge controversy in the COVID era. But I think I will not go into that controversy right now. Maybe Dr. Amit Das might touch on that, and we could answer the queries later on. In the meantime, I'll request Dr. A.K. Das to please start his talk on HCQS in type 2 diabetes.
Thank you, sir. Thank you very much. Dr. Birmani sir has been a great soul of inspiration to young people like us. Hello. I'm not able to see. Hello.
So we can see your presentation. Please go ahead.
But I want to see all of you. No?
But there will be a window created. It will come on the right side of the presentation. Vertical window.
Initially it was coming. Okay. Yeah, thank you, Dr. Birmani sir. I have deep regards to you, and you have been a source of great inspiration to people like me who have as a student, seen you speaking on various topics of internal medicine, and of late you have focused on diabetes, and having the largest experience of talking on national and international platform. We are indebted to have you as a chairperson for this session. And of course, you have rightly pointed out that the greatest controversy in 2020 is none other than hydroxychloroquine. And the controversy still continues. Well, the matter of debate for hydroxychloroquine has been something else other than diabetes, because in diabetes, it is now well accepted and well awarded as one of the adjunct treatment of one of the adjunct treatment for type 2 diabetes. So, however hard people have been hitting this molecule has been growing like anything. And today we'll focus on its role in type 2 diabetics. And let us just go behind what has been in the past. How has this molecule, gone up the ladder and has found prescriptions all across the globe, and interest even in the biggest powers of the world, Donald Trump advocating its use in COVID-19. And today only I found a news clipping where he is still advocating the same molecule, though Anthony Fauci does not approve it. So we have another controversy. That controversy is related to COVID infections. But as far as hydroxychloroquine in diabetics is concerned, there is no controversy. Well, hydroxychloroquine was first approved by the US FDA in 1955, which is almost 65 years back, and it was approved for use in rheumatoid arthritis and lupus. And WHO still includes hydroxychloroquine as one of the essential drugs to be available in a country. In 2001, it was approved for rheumatoid. In 2006, for polymorphic light eruptions, for systemic lupus erythematosus. In 2014, for diabetes. 2014, it was approved for diabetes. Yeah. DCGI approved hydroxychloroquine for use in type 2 diabetics in 2014. What it writes is hydroxychloroquine is indicated as an adjunct to diet and exercise to improve glycemic control of patients on metformin sulfonylurea combination in type 2 diabetics. So way back in 2014, the wordings give us an impression that hydroxychloroquine can be used as a third-line drug after metformin sulfonylurea. Well, today's talk is going to just look at the various pathophysiological advantages, the various scientific evidences which we have in favor of hydroxychloroquine, why it should be used in type 2 diabetics, and where is its position as of now in 2020 as far as treatment of type 2 diabetes is concerned. Well, majority of people who have some kind of interest in the treatment of type 2 diabetics still want to know the mechanism by which hydroxychloroquine can be used in type 2 diabetics. Well, there are 4 basic mechanisms through which hydroxychloroquine has been presumed to have its positive effect in the treatment of type 2 diabetics. 1 is inhibition of insulin degradation, 2 is reduction in inflammation, 3 improvement in insulin sensitivity, and 4 the beta cell preservation. Let me stop here and let me remind you that hydroxychloroquine is one of the chemically modified form of chloroquine, and if I'm not wrong, people who have used chloroquine way back for the treatment of malaria were knowing very well that if you get chloroquine, there is bound to have some kind of hypoglycemia, and people used to give good amount of sugar and of course antiemetic before giving chloroquine. So we knew from beforehand that there is some property of chloroquine which decreases sugars in malaria patients, and that advantage, that effect has been found to be continued with hydroxychloroquine. And here on we have found the basic mechanism through which hydroxychloroquine acts in type 2 diabetics. So the first point is inhibition of insulin degradation, and let's see how this works. We all know that insulin is a very short-lived hormone. It stays in the blood for a very short period of time, probably 4 to 6 minutes only, and it's degraded by different enzymes called insulin degrading enzymes. In short, we call IDEs, and which are insulin proteases, which are glutathione insulin transhydrogenases, and lysosomal proteases. Now, what happens when the insulin binds to its receptor on a cell membrane? It then gets internalized as a receptor insulin complex in the endocytic vesicle. Then inside the cell, this association gets dissociated from its receptor and insulin is released. Now, after the insulin is released, it has its metabolic effect. It's immediately, within minutes, 4 to 6 minutes only, it gets degraded in the acidic environment by the different enzymes, which I already told you, and the receptor is then freed, which goes back and gets attached to the cell surface. So this is the basic pathophysiology. This is the basic way how insulin gets entry inside the cell and it starts acting. Now here comes the action of hydroxychloroquine. What will hydroxychloroquine do? Hydroxychloroquine is going to attach to the receptors and lead to degradation, and because it has some alkalinizing property, it will alkalinize the endocytic vesicle, and insulin degrading enzymes become inactivated in an alkaline pH. Therefore, insulin is not going to get degraded fastly, and there is less of insulin degradation, and the cellular insulin level and thereafter the plasma insulin level starts to increase, and this increase in insulin is going to have hypoglycemic effect, which is our target. But this is how insulin increase in the insulin level leads to lowering of blood glucose, and which is done by hydroxychloroquine. And this is the way hydroxychloroquine exerts one of its action. Now, how do we have evidences? Do we have evidences regarding this? Well, it was found that with increasing concentration of hydroxychloroquine in the blood, the percentage of insulin degradation went down. To so much so that at an HCQS concentration of 40 milligram per ml, the percentage insulin degradation was almost zero. And it has also been found that there is a linear correlation between the insulin level in the blood and the blood hydroxychloroquine concentration. So more the blood concentration of hydroxychloroquine, more insulin available in the blood. Therefore, more sugar control, more sugar lowering effect is there. Hence, as blood hydroxychloroquine concentration increases, there is less of insulin degradation and more plasma insulin level is available. More plasma level, more insulin available for its action to the cells, and hence less of sugars in the blood. We all know that diabetes is a pro-inflammatory state. We have seen that there may be some kind of inflammation in the pancreatic beta cells leading to degradation of the beta, leading to the apoptosis of beta cells and thereby diabetes. So if there is a way by which this inflammation could be reduced, we can have less of beta cell apoptosis, less of inflammation, less of beta cell apoptosis, more insulin availability. We all know that hydroxychloroquine has anti-inflammatory effect, and this has been very well documented in studies which have shown that hydroxychloroquine reduces the CRP level. We all know that CRP is a marker of inflammation. So even in type 2 diabetic patients who were treated with insulin, glimepiride, metformin, and hydroxychloroquine 400 milligram, the HSCRP levels were significantly lower in the treatment arm as compared to the placebo arm. Insulin sensitivity, there have been so many studies, and one of the studies have shown that hydroxychloroquine improves both beta cell function and insulin sensitivity in non-diabetic or I'll say pre-diabetic individuals, and disposition index, which tells you about the insulin sensitivity or decreased insulin resistance has been found to be positively affected by hydroxychloroquine. In a small study of 30 individuals who were non-diabetic but were obese and were in the state of pre-diabetes, which means that there is some amount of insulin resistance in them, were put on hydroxychloroquine, and these values were p-values in both disposition index, which showed the beta cell function, and the insulin sensitivity were significantly favoring hydroxychloroquine use. Hydroxychloroquine has also been found to increase the plasma adiponectin levels.
Sir, you can just right click it on it and say next.
Yeah. Hydroxychloroquine has also been found, this is the same study which I was just telling you about, that hydroxychloroquine improves insulin sensitivity in obese non-diabetic individuals, and this has been clinical pharmacodynamic study where it was shown that at end of 12 weeks, people who were using hydroxychloroquine, the insulin sensitivity index ISI was significantly lower than those individuals who were not being exposed to hydroxychloroquine. And people who, and this was positively affected in insulin resistance also. This is the same study, and it was published in Arthritis Research and Therapy. These are basically small studies, but they have significant impact. And how does it affect on the beta cell preservation? A total of 45 rats were basically divided into two arms, into control arms, and they were having diabetics, and they were put on hydroxychloroquine and diabetes mellitus. The hydroxychloroquine and diabetic group rats were found to have preservation of the islets of Langerhans structures, significant increase in the beta cell mass, an increase in the islet of Langerhans proliferation and neogenesis, and this was significantly correction of significantly increased alpha cell percentage mass also. This is the picture, and this shows that hydroxychloroquine preserves beta cells. They have in islet of Langerhans neogenesis also, and alpha cells are negatively influenced. And there have been so many studies across the globe, national studies, international studies, observational studies, case reports, which have favored the use of hydroxychloroquine in type 2 diabetics. And there have been, real life evidences also. In 1990, there was a study of 38 patients wherein it was found that HbA1c was reduced by almost 3.3%, and insulin requirement was decreased by 30% in individuals who were treated with hydroxychloroquine 200 milligram TID. in 2002, 6 months treatment of hydroxychloroquine 300 milligram BD decreased HbA1c by an absolute amount of 1% than placebo. Here in this study, glucose tolerance and LDL-C levels were also seen to improve in the first 3 months of therapy. And here the number of subjects were 135 and they were on maximum sulfonylurea doses and they were obese patients. And I'm sure you must be, you must be agreeing that as Indians, we have, the classical obese individuals who are basically on highest dose of sulfonylurea and yet their sugars are not controlled. So possibly this study was reflecting our own population as well. There's another study which was published in 2007 in JAMA, which was a study done on rheumatoid arthritis patients of almost 5,000 patients. Patients who went on to develop diabetics, rheumatoid arthritis patients, they were followed for increase in the incidence of new diabetics in those in the rheumatoid arthritis patients. It was interestingly found that individuals who never used hydroxychloroquine had the highest percentage of going on to develop diabetics. And individuals and the group of populations who used hydroxychloroquine continuously for 4 hours, for 4 years, had less number of diabetics. And individuals who used intermittently hydroxychloroquine were in between the two groups. So it meant that hydroxychloroquine has some preventive role or has some anti-diabetic effect and prevents even the development of hydroxychloroquine in patients of rheumatoid arthritis, wherein the intracellular inflammation is very high, when there is a synovial inflammation, and lots of drugs, including steroids, are frequently used. So this was an interesting study, and this went on to prove that rheumatoid, not only in rheumatoid arthritis, hydroxychloroquine per se can be used in diabetic individuals also. So HCQS, if used for more than 4 years, was associated with 77% lower risk of developing diabetics. In 2018, which is 2 years from now, there was a randomized double-blind placebo-controlled trial of hydroxychloroquine versus placebo, where patients who were included were having a high HbA1c of more than 8%. They were obese. They were at least diabetic for more than 12 months. And all of them were inadequately controlled by metformin 1500 milligram and glimepiride 4 milligram therapy. So these patients who were on sulfonylurea metformin combination, poorly controlled on these medicines, were put on hydroxychloroquine in the dose of 400 milligram OD, and one group was put on a placebo drug. So this was a 40 patient group. 20 patients were put on hydroxychloroquine and 20 patients were put on placebo. So herein, where you can see that individuals who were put on hydroxychloroquine had definite reduction in fasting plasma sugar, in postprandial blood sugar, and HbA1c as compared to placebo. From fasting of 178, an average of 178, it went down to 118 in hydroxychloroquine as compared to almost negligible effect of 174 to 149 in patients who were put on placebo. A postprandial from 315 was brought down to 180 in the hydroxychloroquine arm as compared to placebo arm, where it reduced spontaneously from 305 to 263. And HbA1c drop was very interesting to the tune of almost 1.5%. 1.5% as compared to 0.6 in the placebo. So hydroxychloroquine had a definite proof of its hypoglycemic effect in real life as well. So patients with HbA1c of 7.5 to 11% with maximum tolerated dose of sulfoline, urea, and metformin when put on hydroxychloroquine or pioglitazone. Here the study was a comparison of hydroxychloroquine versus pioglitazone 45 milligram. Here you could see that, of course, both drugs were well tolerated, but wherein hydroxychloroquine could reduce HbA1c in by 1.2% with no additional weight gain. In fact, there was a 300-gram weight loss, whereas 45 milligram of pioglitazone led to significant weight. So this conclusion was hydroxychloroquine may be beneficial in uncontrolled type 2 diabetic patient as a third-line agent. This was an international study in 2018. How safe is it when we compare with pioglitazone? This is an Indian study where uncontrolled type 2 diabetic patients, uncontrolled on 2 drug combinations with an HbA1c ranging from 7.5 to 13% and a fasting of more than 7.2 millimole and PP of more than 10 millimole per liter. The number of population here you can see N is 806. International studies had only small number of patients, where this Indian study, we have large number of patients in India. So this was a large group where 800 population were included in the study, and almost 300 were randomized into 2 parts, 135 getting hydroxychloroquine and 132 getting pioglitazone. And here you can see again that the replication was similar. Fasting, we'll go into the graph. Fasting plasma sugar went down from 158 to 118, and postprandial went down from 180 to 144, and HbA1c from 8 to 7. So 1% decrease in HbA1c, and this was presented in the annual ACE 2018, and there was less of discontinuity during the course of treatment owing to side effects. So it was well tolerated, hydroxychloroquine. There was another observational study where 15 type 2 diabetic patients who were not responding on to metformin and sulfonine urea of HbA1c more than 7.5% were prescribed hydroxychloroquine 400 milligram OD for 24 weeks. And here also their HbA1c drop over 6 months were 0.88%, and the change in fasting plasma sugar was also good. And the important point is no patient discontinued drug therapy due to any adverse effects. However, the volume of resentment against hydroxychloroquine of its side effect must be doctors who are into clinical practice and who have been seeing internal medicine patients, who have seen large number of rheumatoid arthritis patients, large number of type 2 diabetic patients. I must, with full, consciousness, tell you that they all have agreed and they all do agree that hydroxychloroquine is basically an innocuous drug. The side effect profile of hydroxychloroquine is wonderful. It is well accepted. The QTC interval prolongation and all other issues are very, very rarely seen in clinical practice. Now, the SGLT2 inhibitor, the blue-eyed baby of diabetes as of now, was again compared with hydroxychloroquine. Herein, the population who were randomized were already on the maximum tolerated dose of a DPP4 inhibitor and metformin combination, and they were randomized to receive either Canagliflozin 300 milligram, which is a high dose, highest dose of Canagliflozin approved, versus 400 milligram OD of hydroxychloroquine. And what we were seeing the glycemic and the safety parameters. And here you can see that HbA1c with hydroxychloroquine decreased to 1.2 versus Canagliflozin 300 milligram of 1.16, and fasting plasma sugar of 31 versus 30, and a PP of 68 versus 66. The point is, whereas SGLT2 inhibitors are taken by both arms, by the national and the international community, hydroxychloroquine is somehow getting a step-by-step treatment, wherein the effect is almost at par. You all must agree that the effect of canagliflozin at 300 milligram is far better than the usually prescribed 100 milligram canagliflozin. And here in this study, we have shown that 300 milligram of canagliflozin is as good as hydroxychloroquine 400 milligram. Or just to say reversely, hydroxychloroquine is as potent as a 300 milligram of canagliflozin, and acceptability to hydroxychloroquine is wonderful. Canagliflozin at 300 milligram has issues of genitourinary tract infections and Fournier's gangrene and bone loss and frequent fractures and all the other issues, while HCQS is devoid of those issues. Physicians and diabetologists who have been using SGLT2 inhibitors have experienced the negative impact of SGLT2 and the time consumed in explaining the disadvantage of SGLT2 before prescribing to our patients is a concern, because you need to explain to your patient about the disadvantages of SGLT2 before you put them on those medicines. Whereas HCQS is often prescribed, really not prescribed. So acceptability profile, I must say, with hydroxychloroquine is better than SGLT2 inhibitors, especially canagliflozin 300 milligram, and the efficacy is at par. Real world evidences also have shown that not only the glycemic advantage, but also the anti-inflammatory effect as compared to HSCRP was better with SGLT2 with this hydroxychloroquine as compared to the other drugs which were compared, that is metformin, glimepiride, pioglitazone, gliptins like sitagliptin, canagliflozin, empagliflozin, DAPA, and bobiglucose. In this, the baseline HbA1c was 8.83 at 48 weeks with 400 milligram of hydroxychloroquine. The HbA1c fell to 6.4. FPG fell from 177 to 102. PPG from 329 to 127. Body weight by 5 kilos almost. HSCRP was significant. So at the end of 48 weeks, almost all SGLT inhibitors were withdrawn. Metformin was reduced, dose was reduced to 1000 milligram. Glimepiride was to 1 milligram. Sitagliptin reduced to 50 milligram. So if we add hydroxychloroquine to a combination of other drugs, it's well tolerated. The advantages are there, and the dose of other drugs are reduced. So more reduction in the glycemic parameters and body weight was observed among patients with higher HSCRP as compared to patients with baseline HSCRP of less than 3 milligram. Most common adverse effects which were seen with hydroxychloroquine was GI intolerance and hypoglycemia, which is well perceived, and none of the patients required medical assistance for hypoglycemia. So to conclude, HCQ effectively improved glycemic control in type 2 diabetic patients and controlled on multiple antidiabetic drugs, and it may emerge as a valuable therapeutic intervention for patients with type 2 diabetes.
Thank you, Dr. Das. Have you concluded?
Thank you very much, sir. Thank you very much. And I think I must end here.
Okay.
And we would invite questions rather than.
I don't see any questions in chat box, but I will. I'll definitely put some questions to you. Starting with, where do you place HCQS in your clinical practice, and what hierarchy would you like to use?
Well, as far as the guidelines are concerned, interestingly, amongst all guidelines, HCQ is not, is not present in any of the national or international guidelines. We must all admit that there are certain group of patients who have high HSCRP when we see the reports and when we have the clinical picture, and they are poorly performing on sulfonylurea, metformin, SGLT2, DPP4 inhibitors. So this is a drug where if you find poorly controlled sugars despite the maximum tolerated dose of oral antidiabetics, where you can, add on this drug. Though this drug does not list in the number of available resources, but when you see in the fine prints of American Diabetes Association guidelines, hydroxychloroquine is there as an adjunct.
So you are saying it is around the fifth or sixth drug, right?
Yeah, fifth or sixth drug. Yeah. In Indians, where the HSCRP remains higher in say some percentage of patients, here you can try this molecule.
Is there any specific group of patients that you feel this drug will be very useful?
I think individuals, obese individuals who are failing on first 4 molecules, you must try this molecule before switching over to insulin.
I think, okay, let me give you a hint. This drug basically we have used for connective tissue disorders, rheumatoid arthritis for a long time with wonderful results. And one of the very commonest presentations in patients with diabetes is periarthritis of the shoulder or a frozen shoulder.
Yeah.
And I've seen that this drug works wonderfully in that. If you just add on this drug, the periarthritis just disappears. So
yeah, and then in that situation also you can add. Yeah.
But that's one of the situations I think is definitely still be very much needed. Okay, there are one or two questions. What is the percentage of A1C reduction in patients uncontrolled on insulin? This is from Dr. Amrinder Prasad Singh from Patna.
The studies which have been done with hydroxychloroquine and combination of drugs, hydroxychloroquine has found to be reducing HbA1c to the tune of 0.8 to 1%. We need to have more studies pointing specifically to the HbA1c reducing potentials, because all of the studies which have been elaborated by me are smaller studies, except the Indian study which had 800 patients. We have a large, population suffering from diabetics, and we still can have bigger trials addressing this. As of now, the potential of reducing HbA1c, I must admit, would be somewhere around 0.5 to 0.75%.
Yeah, but I think after insulin, you don't need any drug. Insulin is such a wonderful
special
drug for reducing. Maybe you're not using the insulin in the proper way. Ultimately, if you have to go to basal bolus regime, that's okay. But then once you put a patient on insulin, the only reason to add any oral drug is to control the high dosage of insulin.
Oh, मेरा slide दिख रहा है?
Yeah. So the other point is that if you are giving a large amount of insulin, and if you are wanting to reduce the dose, you can very well add this drug and see the effects. You may have a reduction in the amount of insulin requirement for that individual. So the amount of insulin goes down.
Second question was how you choose to whom you start HYQ. I think you have already answered this question.
Yeah.
So I don't think there are any other questions. If Dr. Ajay Chhapra would like to ask any question. Dr. Ajay?
It was a wonderful presentation, sir. An excellent deliberation on role of HYQ in diabetes. Familiar but very nice slides. And your job was a little difficult compared to mine because you have to convince the entire fraternity to place a drug and to reflect your talk in the prescriptions and comparing HYQ to SGLT2 inhibitors and DPP4 inhibitors. I think it's a little tough task, but I'd just like to mention the safety profile of this drug. After the COVID era, HYQ came into controversy because of QT prolongation, and we have been using this drug since last more than 18 years of my practice. I'm yet to see a patient on a prolonged QT after a HYQ drug or HYQ. Yeah. So we have to lay emphasis on the safety of this drug, which will be very, very important for all our diabetic patients as well. Because after the safety profile data, they started pouring in, and the WhatsApp University started functioning. We were in trouble related to those drugs. So the safety profile of this drug is excellent. As far as HbA1c reduction compared to SGLT2 inhibitors and DPP4 inhibitors, well, I keep my fingers crossed. I keep my fingers crossed. I have to have some very real world evidence to write this drug before a SGLT2 or a DPP4 inhibitors. Yes, I add this drug on every type 2 diabetic patients who come to me with a complaint of polyarthritis, rheumatoid arthritis, or any other body ache like symptoms, because I'll be very safe. I know their sugars will also go down, and somehow this immunomodulant will help us to control his blood sugar and his pain both. It was excellent deliberation, sir. Thanks a lot. Thank you so much.
Thank you for the nice inputs.
Thank you, sir.
Thanks for the nice inputs, Dr.
So you
Shah.
have to add on
At this point of time, let me add one controversy regarding this.
Yes, sir. Please.
Well, we all have are knowledgeable by the WhatsApp University, as already told by you. But healthcare workers, according to ICMR guidelines, have been recommended by ICMR to take hydroxychloroquine if you are seeing COVID patients. So following those guidelines, I had started hydroxychloroquine for the last 3 months. And interestingly, my sugars, I have been monitoring my sugars. They have never been more than 120 and 130. So
That's
this is a real experience from me. My fastings have already been around 90, 95. They have gone to 80, 82, 85, but never above 85. So this is one thing which I am experiencing, though I am taking it every week. This is not the recommended dose for diabetics, but this is just one anecdotal experience which I wanted to share with all of you.
Right. That's great.
And this is one word of caution also for individuals who are taking it as a precautionary drug. They must have a check of blood sugars on the day of taking hydroxychloroquine, especially.
Yeah, they might go into hypos. Yes.
Yeah, hypo is an issue with them. Yeah.
Yes.
Thank you. Thanks a lot, Dr. Virmani sir and Dr. Ajay.
Thanks.
What Dr. Ajay said, just to add on, I think there is no drug which does not have a side effect.
Absolutely.
And we just do not put the blame on any drug unless we know how to use it.
Yeah, true.
Many times drugs are not used judiciously. If you give HCQS to a patient with a known history of coronary artery disease, he is bound to get prolonged QT syndrome. So that is different, you have to know where to use this, where not to use it. So, okay, anyway, I think we'll go to the next topic. And my friend Dr. Ajay will be talking on a molecule, which I think is the only molecule that we have in the treatment of diabetes, which it is said that just like, motorcycle ka tha, bhar do, fill it, forget it. Here, give it to the patient, forget it. You don't have to monitor.
Very true.
It's such a safe drug. It is the only drug which can be easily licensed in the era of teleconsultation. Without even looking at the patient or physical consultation, you can prescribe this drug blindly. It is the drug of choice in elderly, and now it is also being repurposed as a anti-COVID drug in number of studies. We are seeing the benefits. So I'll request Dr. Ajay Sabra to tell us something about the more than almost 10 years use of DPP4 inhibitors that we have had. What is his experience?
Right.
Yes, Dr.
Thank you. Thank you so much, sir, for the kind introduction. And thank you for chairing this session, sir. We are lucky to have you on this Wednesday evening as a working day. My topic for the day will be very short, and I'll be completing very fast because unlike sir, I have a topic which is cut out actually. I have to just reinforce our faith in a molecule which has been in our domain for more than last 12 years and has been doing wonders to all our type 2 diabetic patients. And with multiple pathophysiological aspects of diabetes coming into the foray since last 5 to 8 years, this drug has done wonders to all our type 2 diabetic patients. So my topic for the day will be DPP4 inhibitors in diabetes management. Now, traditional therapies do not address all islet cell dysfunctions. We know that we have been using metformin and pioglitazone group of drugs, and they help in insulin resistance, impaired insulin action. The insulin resistance parts, whether it's central or peripheral, has been taken care by metformin and pioglitazone group of drugs. Pancreatic cell dysfunction, which, as far as insufficient insulin secretion is concerned, it was taken care of by sulfonylureas and glinides both. But there were other aspects to type 2 diabetes. There's an omnious octet which has to be targeted if you want a complete benefit for all your type 2 diabetic patient, what we call a comprehensive management of type 2 diabetic patients. So there were two other aspects which were not looked upon. 10 or 15 years back, diabetes was just insulin and sugar. We never considered glucagon suppression or glucagon dysfunction. We were never worried about the progressive decline of the beta cell functions. As Sir pointed out, that there were some studies done on rats which proved that we can preserve beta cell mass. Please mark my words, preservation of beta cell mass is victory over diabetes, is a victory over diabetes. So pancreatic islet cell dysfunction, inadequate glucagon suppression and alpha cell dysfunction was taken care of by GLP-1 analogs and DPP-4 inhibitors, and progressive decline of beta cell function was again taken care of by GLP-1 and DPP-4 inhibitors. And DPP-4 inhibitors, on the other hand, also wonderfully showed glucose-dependent insulin secretion from the beta cells, thus causing lesser and lesser hypoglycemia in the patients in whom we were using these drugs. Now, DPP-4 inhibitors mechanism is very simple. It's a glucose-dependent insulin secretion. That is why we say that DPP-4 inhibitors never cause or rarely cause hypoglycemia, because the amount of insulin which is secreted from the beta cell mass is directly proportional to the amount of glucose load in your meal, unlike sulfonylureas. So when you take oral glucose, it goes to the GI tract. From the GI tract, after stimulation by the glucose from the oral meals, GLP-1 and GIP is secreted. This GLP-1 and GIP, they act on the beta cell mass, they produce more insulin, and the glucose was controlled. But the problem was that GLP-1 and GIP had a very short life, very short half-life. They were immediately inactivated by DPP-4 enzyme. So we required a drug which would block DPP-4 enzyme, we call it DPP-4 inhibitors, and thus prolong the action of GLP-1 and GIP. So DPP-4 inhibitors, when we give DPP-4 inhibitors to our patient, they block the DPP-4 enzyme, and GLP-1 and GIP actions are increased, and they cause increased insulin secretion from the beta cell, which pulls down the glucose, and it acts on the alpha cells. It pulls down the glucagon secretion, and glucose production from the liver is also down, and both of them help to maintain the patient's euglycemic level and decrease the patient's blood glucose. Now, here are the ESC and the EASD guideline recommendation 2019. That is European Society of Cardiology and European Association for Study of Diabetes. Now, here we have a patient who is a drug-naive type 2 diabetic patient. The patient is not yet started on on the management of type 2 diabetes. We have just diagnosed the patient. So we have to look for conditions, whether the patient has associated cardiovascular disease, or the patient has high or very high CV risk, that is target organ damage or multiple risk factor. If the patient has any of these conditions, we start the patient directly on SGLT2 inhibitors or GLP-1 receptor agonist. If the HbA1c is above target, we add metformin. If HbA1c is above target, we have number of drugs to add upon, including sulfonylureas and insulin. If the patient did not have any of these high risk problems, we directly put the patient on metformin. After putting the patient on metformin, now we have number of choices for this patient. We have a DPP-4 inhibitor, we have a GLP-1 receptor agonist, we have SGLT2 inhibitors, we have pioglitazone group of drugs. Even if then the HbA1c target is not controlled, we can always combine or give combination therapy to these patients and continue with addition of other agents as outlined above. And still, if the HbA1c is above target, we can use sulfonylureas with lower risk of hypoglycemia. Later generation sulfonylureas can be used, or we can consider basal insulin with lower risk of hypoglycemia. Now, if the patient is already on metformin, what does the guideline says? If the patient is already on metformin and the patient has some associated cardiovascular risk disease, or it has some high target organ damage or multiple risk factor, again, if the patient has these risks, we add an SGLT2 inhibitor or GLP-1 receptor agonist. If HbA1c is above target, we consider adding other classes of drug and control his blood sugar. If the patient doesn't have these problems, well, we have number of drugs which can be added to the kitty, and we can control his blood glucose, and we can later on add sulfonylureas with low risk of hypoglycemia and basal insulin, and if required we can always go for basal bolus dose of insulin as well. In our country, a third world country like Sri Lanka, Pakistan, Afghanistan, India, Bangladesh, sulfonylurea is a drug of choice. After introduction of newer molecules, SGLT2 inhibitors and DP4 inhibitors, I must admit that I still use a lot of sulfonylureas in my type 2 diabetic patients with wonderful advantages. And now recent studies coming in for modified release glycoside, which can also be used in CKD up to CKD stage 3. Well, sulfonylurea is one of my drug of choice, including other drugs, of course. Now, this is the ADA 2020 guideline, and it says that the first line therapy for management of diabetes is metformin and comprehensive lifestyle management, and we have to avoid clinical inertia. So every 3 to 6 months, his therapy has to be modified. I will not go into the detail of this complex looking chart, but I just want to say that if your patient belongs to a high risk category like cardiovascular disease, CKD, or heart failure, please try to put the patient on SGLT2 inhibitors or try to put the patient on GLP-1 receptor agonist, and then add on drug depending on patient's comorbid conditions. But if the patient doesn't have any high risk problems, you can always start the patient on metformin and add a very simple drug like DPP4 inhibitor or SGLT2 inhibitor, or if the patient has some cost constraints, you can go for sulfonylureas. If the patient is very obese and you want to pull the patient's weight down, you can always start with GLP-1 receptor agonist or SGLT2 inhibitors. But if you see all these 4 boxes, DPP4 inhibitors, it somehow fits into all the categories. It somehow fit into all the categories of all the patients, whether it's a high risk group patient, or whether a patient requires weight loss, or whether you want to minimize hypoglycemia, or is a cost effective issue, then of course vildagliptin now is very, very cost efficient and we can use in our patients as well. Now, this is the ADA 2020 guidelines. The pharmacological therapy of type 2 diabetes, recommendation 9.4 says that metformin is the preferred initial pharmacological agent for treatment of type 2 diabetes. Now, once initiated, metformin should be continued as long as it is tolerated and not contraindicated. Other agents, including insulin, should be added to metformin. The recommendation 9.6 states that early combination therapy can be considered in some patients at treatment initiation to extend the time to treatment failure. Now, here I would like to mention about the VERIFY trial. Now, this is one of the largest trial, one of the first trials which was conducted in the earlier phase of type 2 diabetes. All the other trials, when you see, they were conducted on the later phase of diabetes. This is the trial which was conducted in the earlier phase of diabetes, when the patient's HbA1c was somewhere around 6.5 to 7%. And this trial suggests that more intensive early treatment has some benefit and should be considered through a shared decision-making process with patient as appropriate. Now, verified trial suggested that when you start a patient on metformin alone, the patient is bound to have his blood sugars increased after 1.5 years. In Indian scenario, after 18 months, the metformin monotherapy fails. But if you start the patient on metformin plus vildagliptin combination, the time to initial failure is about 4.5 years. That's a huge time, 3 years more than the current failure in Indian patients. So if you start a patient on a combination therapy of metformin and vilda, the patient can maintain his euglycemic status up to 4.5 years. And the requirement for the third drug is reduced by 58% if you start with a combination therapy. Since the absolute effectiveness of most oral medications rarely exceed 1%, initial combination therapy should be considered in patients presenting with A1C levels of more than 1.5 to 2% above target. Now, this is a comparison of DPP4 inhibitors. They score very well, all the molecules. They are orally administered drug. Renal excretion is present in all of them except Lina. Lina has very minor renal excretion. That is why linagliptin is the only drug which can be used even in CKD stage 5 or in dialysis patients as well. Dose reduction with renal impairment is not required with linagliptin. Otherwise, we have to reduce the dose of all sita, vilda, sexa, and teneligliptin. All the drugs we have to reduce the dose in case of renal impairment. I specifically mentioned teneligliptin because we have no large studies of teneligliptin as of now. We have studies of all sita, vilda, sexa, and lina, but teneligliptin still requires a lot of studies to prove that it's a safe drug in cases of renal impairment. Please remember, DPP4 inhibitors are not contraindicated in cases of renal impairment. It is just that we are able to maintain patients' euglycemic level with a lower dose. So the dose of the drug is decreased in cases of sita, vilda, sexa, and alogliptin. None of them require dose reduction in case of hepatic impairment. Drug-drug interaction potential is very low. HbA1c lowering efficacy is almost same in all of them. Monotherapy with HbA1c lowering, well, highest is vildagliptin. That may be because vildagliptin is always required in a BD dose. In BD dose, you will be able to achieve the receptor blockage of more than 96%. Otherwise, if you give an OD dose, the receptor blockage is not more than 40% in case of vildagliptin. So BD dose, it reduces HbA1c by more than 1%. Now, this is the meta-analysis, CV safety of gliptins as a class, meta-analysis of 44 trials, and DPP4 inhibitor were better than the comparators. Comparators were, of course, were metformin, glimepiride, glyburide, glipizide, acarbose, voglibose, pios, rossi, lira, and exenatide all. And after meta-analysis of 70 trials with more than 42,000 patients, the mean follow-up was 44.1 week, and this drug showed a safety profile of about 29% with a significant p-value of less than 0.001. Greater reduction of risk in major CV events with vildagliptin was observed, more than 39%. Risk of major CV events like acute MI, stroke mortality, and CV mortality was 39% less with vildagliptin. Of course, there were some trials to suggest that sexagliptin showed increased hospitalization due to heart failure, not due to other MACE activities, but due to heart failure. And still the studies are on. There are pharma companies which have launched a combination of sexa and dapa. Is already there in the market, and we have to see whether sexa and dapa can neutralize the heart failure advantages and disadvantages of each other. That is to be seen in near future. So no increased risk of acute pancreatitis with GLP-1 based therapies. I am yet to see a patient of type 2 diabetes on DPP4 inhibitors reporting with pancreatitis. I have never seen that. We have read that in test books, but yes, I have data of 8 patients with me in last 5 years who showed increased amylase and lipase without any pain of pancreatitis or radiographic change of pancreatitis. They just had increased amylase and lipase when they were put on DPP4 inhibitors. All 8 of them, we withdrew DPP4 inhibitors and put them on other drugs, and their amylase and lipase went back to normal levels. So patients with type 2 diabetes have a 2 times more risk of acute pancreatitis compared with healthy individuals. Safety analysis of all phase 2, 3, 4 studies demonstrated that incidence of acute pancreatitis was similar for vilda and all comparators. No causal association between pancreatic adverse events and GLP-1 based therapies has been found so far. So vilda, just a short 2 slides on vilda. Potent selective reversible inhibitor of DPP4, binds covalently to DPP4 enzyme and inhibits it. Weak inhibition of and rapid dissociation for DPP8 and DPP9. Dose of 50 and 100 milligram of vilda provides almost complete inhibition of DPP4 for approximately 12 hours, about 40% inhibition by 24 hours. Approved in India, Europe, and more than 125 countries for treatment of type 2 diabetes. Now, vilda is indicated as mono. It is indicated as dual or oral therapy in combination with metformin, sulfonylurea, pioglitazone group of drugs. as triple oral therapy in combination with sulfonylureas, metformin. It can also be combined with insulin. We usually, when we put a patient on insulin, an old type 2 diabetic patient, more than 10 years of diabetes, we put a patient on insulin. I prefer to continue vildagliptin and metformin and like to withdraw sulfonylureas, but continue with vilda and metformin with insulin, and it gives us wonderful results because the mechanism of action of secretion of insulin by DP4 inhibitor is quite different from sulfonylureas. Thank you so much for your patient hearing. Thanks a lot.
Thank you, Dr. Ajay Chabra, for a wonderful presentation. I think you have covered everything.
Thanks, sir.
I don't think there are any questions in the chat box, but if anybody else, I can't see any questions. Any questions chat box, Umang?
No, sir. Actually, right now there is no question in the chat box. So you can conclude the session, sir, according to you.
Okay.
Sir, there is chat box does not have a question, but we have 135 doctors already logged in onto PAN, this region of Bihar.
How many?
That's great.
134 doctors
Okay,
are
good.
already live.
Good.
That's great. That's great.
That's good.
Thank you, Virmani sir. Thanks a lot. And it was nice to have you in the evening, sir.
Thank you, Ajay and
I would like to add one thing. Thank you very much. This is my heartiest thanks to Birwani sir, Dr. A.K. Das sir, and Chabra sir. Since it was a working day, you all have given your time to us. Thank you very much, sir, for such a classified information about hydroxychloroquine, HYQ, and the Valdep. This is my heartiest thanks to all of you, and please be safe. Thank you very much, sir.
Thank
Good
you.
night.
Thank you. Thank you. Good night. Take care. Bye.
Hello.